I haven't seen this type of lecture discussion workshop done at Eyecare before, so there's also feedback forms on all of your tables. Everyone's got one of those. I'd be actually really interested to see if you liked the format, if you thought it worked well, if you'd like to do it again, and we'll try and run more of those next year if it is popular. But for now, I'd just like to hand over to Heidelberg to do their live OCT demonstration. So I'm going to hand over to Chris Modi, who's the Director of Clinical Services for Heidelberg, and Dr. Manish Gupta, who is a local ophthalmologist as well. Thank you very much. Can you welcome them here?
Right. Good morning, ladies and gentlemen. Well, I'm truly astounded that we've got such a packed room today, so hopefully we can live up to expectations and deliver an interesting and informative and educational session. The title is OCT Live, and the reason we came up with this concept is that so many times we sit there and we discuss OCT images and people are reviewing them, and it seems very out of context. So we've been very kindly supported by a number of patient volunteers recruited by Dr. Gupta, and they've kindly volunteered to have their eyes scanned live. We've got a variety of different macular pathologies to review, but before we start that, what we will do is go through what is normal to start with. And I think it's important to review normal OCT anatomy and also a normal or a very straightforward approach to macular assessment. In doing that, so we're going to scan one of my colleagues, Nick Timms, who's again kindly volunteered to have his eyes scanned. All of our subjects are undilated. Obviously, we didn't want to put drops into people's eyes if they've then got to travel home from this meeting. It seemed a little unnecessary. Okay, so we're going to start out with our first live session. What we'll be doing is we'll introduce the patients to you. They will give you their history, their vision, signs and symptoms, and perhaps some initial investigations or scans. We'll then go through the live component and review what we visualized, and we'll then pose some questions for you to discuss in a round table format. We'll then review the images in a little bit more detail. Okay, so that's the basic format for today. So if we could initially then just move over to the external camera, please. Perfect. Okay, so first of all, in trying to set a patient up for any kind of clinical examination, a few moments just getting the patient comfortable and positioned is important. And particularly with OCT, it's very important that the patient maintains a head-forward position throughout the examination. If they don't, they drift away. It's very difficult to maintain an accurate OCT scan position. Okay, if we go over to the live instrument feed now, please. Okay. So during any OCT assessment, it's really worthwhile just to start out by assessing the fundus. Now, with a scanning laser ophthalmoscope, which is what we're using here, we're able to scan the eye using different wavelengths of light. And we're using infrared light, near-infrared light. This means it's invisible to the patient, so patient compliance is extremely high, and we get a very high-resolution image. We can visualize the small microvascular structure. We'll see pigmentary change. Fluid is very easily detected. So we're going to start out with a disc image, sorry, a macular image, then a disc-centered image. And finally, a temporal to macular field. And the reason I say this is that everyone in this audience who's involved in patient examination is an expert in fundoscopy. So it's important to start using simple, familiar techniques to assess the back of the eye and to identify structure. So obviously, Nick's eyes are normal and nothing of any great note there. So we'll move on to the OCT examination now. The first thing to do is to identify the central fovea. And what we're looking for is this shallow depression. And note the bright reflex at the center of the fovea. This means we've got a foveal-centered scan. We're then doing a scan in a vertical orientation. And what we're looking for here again is any structure that's going to conform to the midline. So if you've got a vascular occlusion, in glaucoma you see arcuate retinal fiber loss. doing a vertically orientated scan allows us to identify change. Again, the macular scan, so this is a dense macular scan, multiple B scans in different locations. And each one of these scans, not a single scan, but we're actually averaging 16 frames at each point to give this very high resolution cross-sectional image. Okay, we're then going on to a glaucoma scan, just for completeness, and we'll do a circle scan. And once again, what we're going to do is stabilize the image using an eye tracking system. The image becomes stable. We can then position the circle scan precisely over the optic nerve head on a static image, and then we're acquiring 100 frames in the same location. Okay, we just escape there for a moment, Phil. Now, obviously it's important to be able to acquire these images, but more often than not, when you're using OCT in a primary care setting, you're seeing the disease at the very earliest presentation. And therefore, the problems may not be initially manifest. So the ability to go back and to re-examine the same location is of paramount importance. That's important in macular disease, but it's of paramount importance in glaucoma. The reason there is that the scans look normal in a glaucoma subject. Okay, there's nothing you can look at to tell you that this is abnormal, unlike macular disease. So you're relying on the device's ability to perform physiological measurement and to identify retinal atrophy and thinning of retinal tissues to tell you whether or not we're seeing progression. So we have to go back to the same location. So what Phil's done is simply to set the retinal nerve fiber scan as a reference scan. And we're going to repeat that scan now. And what we're doing is taking 1,100 data points from the fundus reflectance image, and that tells us or provides coordinates for that OCT scan, so we can precisely repeat the scan. So we'll just go through the follow-up scan process. This menu is now live, and we can select the scan that we've previously identified. So the eye tracking system is now kicked in. We've got a live scan, let the quality build to 100 frames, and then acquire the image. Okay, so how accurately can we do that? Typically, we get a repeatability between scans of 1 to 2 micron variability between examinations. And if you're looking at a glaucoma subject, where the global loss of retinal nerve fiber layer is typically around about 2 microns per year, you need a very high level of repeatability to detect evidence of progression. So Phil, if we could load the follow-up scan, and we can compare the two scans side by side. If you just zoom in on the cross-sections for us, Phil. If we look at the shadows cast by the retinal blood vessels around the optic nerve head, you'll see that they precisely line up between the examinations. But if we look at go to printing a report now, Phil, if we can go to print a trend examination by exams, that's it. And okay, this is our baseline examination, this is our follow-up, and this is our change, and this is where I put my head in the lion's mouth. And we sure enough have achieved 1 to 2 micron variability between scans. Okay, so this is absolutely essential if you're planning on using OCT for glaucoma monitoring. You've got to be able to, one, demonstrate a progressive change and demonstrate that progression accurately and effectively. Okay, so really 1 to 2 micron variation between examinations is absolutely essential. Okay, let's go back to the actual conventional scans. If we look at the 3 fundus images to start with. So we can select the 3 fundus images and very quickly create a wide field image. Okay, so this gives us a field of view that's approximately 30 by about 50 degrees. Okay, and these images can be extracted from the conventional OCT scans in the same process created. Again, optic nerve head, retinal vasculature, you can see the arterioles, venials, and small order bifurcation of blood vessels. Okay, Phil, if we can look at the OCT scan, go for the horizontal line, please. Okay, when we're looking at an OCT scan, what we're looking for is this sort of shallow, sort of roller coaster Big Dipper profile at the fovea. Okay, this is a normal foveal profile. The outer Retina has a gentle concurvature to it, generally speaking, and what we're looking for is this clear laminar structure to the retina. Phil, could we just zoom in a little bit on the OCT cross-section, please? Okay, so going from inside to out, this right reflex we see on the surface, we can just see here and here, is the internal limiting membrane, and this represents the pedicle aspect of the Muller cells. The first hyperreflective band that we can visualize then is retinal nerve fiber layer, then the ganglion cell layer, the inner plexiform, and the inner nuclear layer, the outer plexiform, which comes down to this point here. What we're seeing here is the margin of Henle's fiber layer. We've then got the outer nuclear layer, external limiting membrane, which is the apical aspect of the Muller cells. The Muller cells pass all the way through the retina, providing structure and metabolic function. We've then got the myoid of the photoreceptors, the ellipsoid zone. So the myoid is responsible for protein synthesis, the ellipsoid for chemical energy production. If either of these bands are disrupted, or in fact the external limiting membrane, in a scan that otherwise looks normal, you can probably account for why a patient might be visually symptomatic. Okay, so the integrity of these two bands, or three bands, is very important. Then got the outer segments of the photoreceptors, the RPE photoreceptor interdigitation, and then finally the Bruch's membrane RPE complex. We can't see Bruch's membrane as a separate layer in normal subjects, but in pathology we can sometimes identify Bruch's membrane separately. And finally, we can see the large choroidal vessels. Okay, so that's the normal structure. Let's have a look at the vertical scan, Phil, for a moment. Okay, so again, now vertically oriented scan. So if we've got any changes in one hemisphere or the other, it's immediately obvious on a vertically oriented scan. If you're doing horizontal scans and in a volume scan, then you may not necessarily detect the changes in one hemisphere versus the other as quickly as you will see it in a vertically oriented scan. Okay. Finally, the volume scan. Okay, so multiple cross-sections at different locations. Okay, so we're averaging 16 frames per cross-section. The line scans were 100 frames in each location for very, very high quality. We can look at this as a three-dimensional image. And this is extremely useful for patient education to explain some of the abstract concepts associated with ocular disease. Patients are often very familiar with a fundus recording, but less familiar with an OCT scan, so it just helps with that explanation of the changes that you might be observing. We can look at thickness profiles, and this gives us an interactive A-scan reading. So wherever we move the cursor to, you can see we're getting an interactive measurement of retinal thickness at that location. Okay, and finally, the last one is OCT thickness maps, and this gives us a color-coded height map, which gives us a good indication of where we're going to see abnormal retinal thickening or retinal atrophy. Okay. Typically, we're seeing a depression at the fovea, a lower measurement of retinal thickness, and the central subfield is typically around about 270 to 280 microns when measured on SPECTRALIS. All OCT devices measure the eye slightly differently, so you need to check with your OCT manufacturer as to how those measurements are derived. We measure from Bruch's membrane to internal limiting membrane, so we create a thicker measurement, but the surface of the RPE can be used as a measurement, external limiting membrane. So it's important to know how the measurements are being derived. Okay. Right, so we've had a chance to look at normal. So now we'll start to look at some cases where we've got patients with some macular changes. So we're going to call on our first patient volunteer, which is Marion. If Marion would like to come and have a seat. And I'll hand over to Mr. Gupta, who's going to introduce our first case for us.
This is our first patient, Marion O'Neill. She presented to me for the first time in March 2011 with some distorted vision in the right eye. At that time, her vision was 6/12 in the right and 6/6 in the left eye. And if you look at the OCT in the right eye, you can see some pigment epithelial detachment there and some intraretinal fluid. So we did a fluorescein angiogram which confirmed wet macular degeneration, and the patient was listed for injections in the right eye. At that time, we were only giving Lucentis injections. So first injection was done, and then this is in January 2012. This is after 3 injections in the right eye. You can see the pigment epithelial detachment is settled and you don't see any fluid here. So her vision was almost normal at that time, though there was some disruption of the photoreceptor layer. She came back in March 2012, and you can see PED is coming back, and again there is some fluid coming back in the right eye, and her vision was slightly poor. It was down to 70 letters, which wasn't that bad. It comes to around 6/9, but at that time we listed her for another few more injections in the right eye. And when we saw her in November 2013, this was after 8 injections. You could see again it back to normal. There is a bit of atrophy there, but there is no sign of any fluid. So we kept her under observation, and she didn't receive any injection for good few years. But last year in August, again she presented with distorted vision in both eyes now. You can see the right eye, reappearance of some fluid here, and then in the left eye you can see a big pigment epithelial detachment with subretinal fluid and some intraretinal fluid. So at that time we have started using Eyecare for our patients. So she was listed for 3 Eyecare at monthly interval in both eyes. And this is her in December 2016. You could see the retina is quite settled in both eyes with good vision. So as per protocol, she's listed for another 4 injections every 2 months in each eye. Unfortunately, we couldn't give an injection in the right eye just now because her INR was high, because if it is more than 3, we don't do injections. But she's under a regular follow-up for more injections. So this was in December last year, and now we have the live images for this patient.
Right, well now we're over to the live scan element. So if you could go onto the instrument feed, please. And we'll start with Marion's examination. So it's a lady with wet macular degeneration. She's under treatment, so we want to determine whether or not further treatment might be required. So key things we're looking for is presence or increase in subretinal fluid, evidence of intraretinal fluid and an increase. We're looking for evidence of exudate, increased retinal thickening, and evidence of, obviously, macular hemorrhage. So if we start with our live scan, then we're looking at let's first start looking at the infrared reflectance image, and we can already start to see some pigmentary change centrally. Okay. So eye track. Now I've got a stable image. We're now averaging multiple images. We're doing a vertical oriented scan. Okay. And again, a macular volume scan. And notice that Marion hasn't got stable vision because of her macular changes. She's unable to monitor the fixation target, but it doesn't matter because with eye tracking, we're able to still record the macular scan very effectively. Can I have a quick look at the other eye, Phil, please? Okay, you see the posterior hyaloid, posterior vitreous detachment, vertical scan. Okay, so again, the RPE change is very, very visible using infrared reflectance. Okay, that's fine, Phil. Thank you. Lovely. Excellent. Okay, if we can just escape there and we'll look at the images we've acquired. Okay, so we start with the right eye, Phil. Okay, so this is our horizontally oriented line scan. If you just make the fundus image larger, Phil, please. Okay, and this is the key thing with infrared reflectance. The changes we can see here in the central macula, very clearly identified. We've got pale reflective areas. This usually indicates sign of atrophy. We've got some pigmentary changes we can see here, possibly some disruption or disorganization of photoreceptors. And then when we look at the OCT cross-section, if we just move the cursor, Phil, just over to this border here, okay, you can see that precisely correlates there to the changes that we're seeing in the fundus reflectance image, and then the other border just here. Okay, and what we're seeing here is just a small area of atrophy or thinning, and we're getting increased signal in the choroid, okay, indicating we've got a window defect in that location, and we've got a gradual elevation there of the retinal pigment epithelium, and then some sub-RPE sort of reflective material. Again, follow the line here. The outer nuclear layer of the photoreceptor seems to just disappear where we've got that focal area of atrophy. So again, we've got some loss of photoreceptors. And again, more continuous on the nasal sign, relatively normal. But no obvious signs of subretinal fluid. There's this little dark area here, which is probably some sub-RPE fluid. But the question is that long-standing or not? So, Mr. Gupta, in a scan like this, what were you particularly looking for in terms of your decision-making?
You had looked at the previous scan before the 3 Eylea injections. She had some intraretinal fluid and possibly some subretinal fluid as well, which is gone now. You don't see, and the layers are quite normal there till this area where you can see a patch of atrophy. And this is a small possible pigment epithelial detachment, but you don't see any intra or subretinal fluid. So she has responded well to the injections. And I think this is the right eye, and similarly the left eye. Could you bring the left eye, please? Again, the left eye, you could see that there are some subtle RPE changes, but no sign of intra or subretinal fluid here. So both eyes have responded well to 3 Eylea injections, which we gave at a monthly interval. And now, as per protocol, we have listed her for another 4 injections, which will be every 2 months. And we'll see her in the clinic in around 6 months' time, unless until she notices any distorted vision before that. But she's already on some treatment, so effectively we don't have to do anything till she comes back to us in 6 months' time.
Okay, so if, let's say this patient were to be, we saw this kind of appearance in the eye, this was the presenting signs or presenting appearance, what would be your sort of the thing that the optometrist should be thinking about in terms of their assessment of the patient? When should they be thinking about referring a patient with just this kind of appearance? Do they need to, could they monitor a patient like this?
I think if you can monitor the patient with serial OCTs like every month or every 2 months, I think they can monitor it. And if they don't see any, if you see any, like he suggested, if you see any recent hemorrhage at the macular area or some subretinal fluid or intraretinal fluid, or if patient they themselves complains of any distortion, then that means something is going on. If it is an occult membrane, sometimes you don't see any fluid on the OCTs, but if we do a fluorescein angiogram, then we can see mild leakage. And if we should go with the patient's symptoms. If they say, I definitely see a distortion, but we don't see anything on the OCT, we still need to refer the patient. But if patients are happy, they are maintaining their vision, and if you are happy with the scan like this, where you don't see any fluid, then the patient can be monitored.
So when we're thinking about subretinal fluid, well, the first thing that immediately springs to mind, obviously, is wet macular degeneration and choroidal neovascularization as the cause. To that list, then I think we also need to be thinking about other possible causes then. So again, it could be choroidal neovascularization secondary to myopia, high myopia. Okay, that needs to be added to your list. A very common occurrence and common presentation to optometric practice obviously is patients with central serous retinopathy. Increasingly, though, we're seeing CSR in older subjects. So the question then is, are we seeing an early presentation of wet AMD or a late presentation of central serous retinopathy? And one thing you can do that will help you in your differential, if you see subretinal fluid and you see evidence of a very thick choroid, so more than twice the central foveal thickness, then you should be thinking as possibly CSR as the cause. If you see subretinal fluid and a very thin choroid, then wet AMD. Okay, so it's a very simple kind of rule of thumb.
This is one criteria. The other criteria is look at the RPE.
Yeah.
AMD is the disease of RPE, and in CSR or other conditions, pigment epithelium probably would be intact.
Yeah.
You won't see any lifting, any drusen, any bumps on the pigment epithelium. But in age-related macular degeneration, definitely there would be some wear and tear of the RPE. And look at the other eye as well, because usually AMD is in both eyes. If one eye present with wet changes, there could be some subtle changes in the other eye as well.
Other things to think about then, obviously, diabetic macular edema can cause subretinal fluid, vascular occlusion can cause subretinal fluid. So the list is quite long, and then we obviously have inflammatory causes. And there are rare things like Harada's disease. So there are lots and lots of causes for subretinal fluid. So your differential needs to be quite wide initially, and you need to be using OCT to help you provide evidence to narrow your differential diagnosis and come up with a strong clinical decision. Remember, OCT is part of your overall clinical assessment of the patient. Okay.
We do a teach and treat clinic in Stop Hill Hospital, and I always tell my optom that don't make a diagnosis just on the basis of OCT. It will help you in making the diagnosis, but it is the full clinical picture that will help you in making a diagnosis. So always examine the patient in full, including anterior and posterior segments, and then rely on the OCT up to a certain extent. Never make a diagnosis just on the basis of OCT.
Okay, so if we can move on to our next subject, could we have the PowerPoint presentation, please?
Okay. This is Mr. Skillen, who presented in July 2013 with right supratemporal branch vein occlusion. You can see multiple blot hemorrhages, some cotton wool spots, and there was slight thickening at the macula, but at that time it was decided not to treat him, and then probably he was discharged from the clinic. He presented again in March 2015 without any treatment, and you can see the hemorrhages have disappeared, but there is chronic cystoid macular edema with a possible epiretinal membrane. At that time his vision was 50 letters, and collaterals were noted at the disc, so it was decided that since the collaterals have developed and macular edema is chronic, he was discharged from the clinic without any treatment. He presented again last year in June at the Gartnavel Hospital, where my colleague saw him, and when he noted this is similar. You could see that cystoid macular edema has not changed, but they possibly noted some new vessels at the disc, so he was referred to me when I saw him in August last year. We did a fluorescein angiogram because we thought there could be some new vessels, and the vessels showed some leakage. So that is one way you could differentiate between the collaterals and the new vessels. Collaterals never leak, but new vessels will always leak. So we saw some leakage and we saw some ischemia in the macular area. So what we did, we listed him for 3 injections and laser treatment. So we gave him 1 Lucentis, did pan-retinal photocoagulation, and did another 2 Lucentis afterwards. And this is his OCT in December last year. Unfortunately, we couldn't do anything for the macular edema because there was ischemia, it's chronic, there is an epiretinal membrane, but the new vessels disappeared because of the laser treatment. So now we have just decided to see him on a regular basis without giving him any more treatment, because because it's chronic edema and it won't respond to any treatment. That's what we have seen in, he's not responded in the last 4 years. So he will be followed up just on a regular basis for few years, maybe 1 or 2 years, and then we can discharge him care of the local optician.
So we're going to start out just using fundus imaging. Okay, and again we see the power of infrared reflectance in identifying the obvious structural changes. So infrared light, whilst it's long wavelength, it's invisible to the patient and it penetrates the ocular structures deeply, it's very easily absorbed. And the thing it's easily absorbed by is fluid. So either fluid within the retina, underneath the retina, or underneath the RPE. So if we want to identify where we have breakdown in blood-retinal barrier, it's very, very obvious from this image. And this is the key, it's the structural information you can see within this fundus image that is unique. Again, we'll have a look at the temporal fundus film if we can. Okay, perfect. And while we're there, Phil, could you just drop an OCT scan through this area just at the bottom? It's by the vessel there, that's it, perfect. Okay, so we can see that little area there. And the question, is that a new vessel? Is that a hemorrhage? We can just drop an OCT scan through that particular location. If we go back to the central macula, Phil. Down a little bit, please. Smooth the scan down for me, that's it. Okay, perfect. Okay, vertical scan. And we go for a volume scan as well. Thank you. Okay, if we escape there. Okay, Phil, if we could just create a composite image from the 3 fundus pictures. Okay. Okay, so that gives us a nice wide field view of what we're seeing at the back of the eye. So if we look at the scan, okay, most of the changes are in the superior half and temporal part of the macula, that we have got some changes here. And the question is, what we're looking at here, is this just a vitreous hemorrhage or is this a new vessel? My guess is probably just a vitreous hemorrhage, but it's difficult to be absolutely sure. We'll have to look at the OCT scan in a bit more detail. And we've got high reflectivity in the vitreous, which is then casting a shadow on the OCT scan, which is precisely located at this point here. So it's most likely that it's a vitreous hemorrhage that we're looking at and not a new vessel. If we were a new vessel, we'd be able to see the vascular communication coming from the surface of the retina breaking through the internal limiting membrane. Okay, but it's important that we identify any evidence, obviously, of new vessels, as that would potentially have a risk for vitreous hemorrhage, and it indicates maybe there's more ischemic change in the eye, and again, probably further treatment might be required.
If we see vitreous hemorrhage, that means that we need to do more laser. Otherwise, more ischemia, more hemorrhage, patient can develop neovascular glaucoma. We need to prevent that. Usually that is not very common after branch vein occlusion, But if we see vitreous hemorrhage, that means some vessels are still leaky, so we definitely need to do some laser treatment here.
Okay, Phil, if we go to the macular, central macular scans. So the obvious thing here, obviously, is we've got very significant retinal thickening. When we're looking at an OCT scan, it's wise to take a sort of an inside-out approach. So we start from the inner retina and work our way out. And I want to ask a number of things. Very simply, does the scan look normal or not? Well, obviously, it doesn't look normal. Look at the inner retinal profile. Does that look normal? No. Does the outer retinal profile look okay? Yeah, that's actually relatively normal. Can I see the RPE? And can I see the retinal nerve fiber layer? Yeah, I can see all of those elements. And we've got a nice, clearly defined sort of stroma to the retina. So it's a good quality scan fit for assessment. Okay, on the surface then, we've got this highly reflective material. And immediately beneath that, it appears to be slightly corrugated. It's quite thickened. Okay, that's the first thing you should be looking for. Okay, we've got the other obvious changes. We've got lots of hypo-reflective voids. Okay, and they're basically sort of cyst-shaped. Where are they actually occurring? Well, they're occurring in the inner nuclear layer and in the outer plexiform anterior to Henle's fiber layer. Henle's fiber layer is about this level here. So all the cystic change is anterior to that. If you see cystic change in that area, we're looking at breakdown of blood-retinal barrier, and retinal disease or diabetes is the most likely cause. Okay? The RP appears to be intact, as do the outer retinal layers, although we're getting some shadowing here. This is again caused by the fluid voids within the OCT scan. A number of you I heard discussing this hyper-reflective material here. Again, where's that located? It's the level of the outer plexiform. And the outer plexiform and Henle's fiber layer effectively act as a middle limiting membrane. And what we're seeing here is lipid and lipoprotein exudate, which is very, very reflective, and we can also see it on the fundus reflectance image. And this is a sign that this is a long-standing change. Okay?
Sometimes we are confused when we look at the fundus whether these are exudates, drusen, or cotton wool spots. Means cotton wool spots are usually fluffy, exudates are usually bright, and drusen are more regular in shape. And if you are confused, you can do an OCT. Like exudates are usually in the retinal layers, cotton wool spots should be in the superficial layers, and drusen would be underneath the RPE. So location of the lesion would tell you whether it's drusen or an exudate or a cotton wool spot.
Phil, can we have a look at the volume scan? Okay, and so the changes are all the way out throughout the central macula, and again, they're all fairly consistent in appearance. Okay, if you look at the thickness map, and again, warm colors indicate retinal thickening. So again, in the sort of central area, we go macular edema. There's obviously quite marked retinal thickening. Now, in terms of kind of if you identify this kind of change, that in itself is not particularly important, but it is important to the clinician who's then treating the patient and looking for response to their therapy. So it's important to get that measurement. Okay. Right, shall we look at our last patient as we're running out of time? So we could go back to the PowerPoint presentation, please.
So my last patient is a 72-year-old chap who is type 2 diabetic for the past 19 years. He also developed left supratemporal branch vein occlusion. He's pseudophakic with right amblyopia. He has got compromised renal functions due to diabetes. His HbA1c was 60, which is normally not that bad, which is normally between 40 and 50. So this is him in January 2015. You can see vision is 624 in the right eye because of amblyopia. You can see some cystic spaces with bit of subretinal fluid. The left eye, you could see a bit of thickening there and cysts, intraretinal cysts here. So we listed him for the course of 3 Lucentis injections in the left eye, but he could get only 1 because he was admitted in the hospital for various other medical reasons. So the injection was done in February 2015, and this is his left eye. Slightly better after just one injection. So what we did, I think we listed him, we didn't give him any treatment at that stage because probably he had an heart attack and we wanted to wait for 3 months before starting him on some treatment again. We saw him in August, and at that time you could see the edema is coming back. The right eye was getting worse as well, so we listed him for Lucentis in both eyes. It was a course of 3 injections in each eye. And again, he missed few appointments because of hospital admission, but this is him in December 2015. Vision is normal, and you could see the macula looks normal in both eyes. Slightly thick on the right side, but his vision has never been more than 624. We again saw him in November. Unfortunately, he missed few appointments because of hospital admission. He had a TIA in May 2016 and then heart attack in August. You could see the edema was coming back, bit of subretinal fluid, cystic spaces there in both eyes, in fact worse on the right side. Vision has dropped down to 636 in the right and 618 in the left eye. So because he had a medical history of stroke and heart attack, this time instead of giving him anti-VEGF, we listed him for Ozurdex in each eye. So he received first Ozurdex in the right eye, I think in December, and this is his OCT scan. The right eye looks better. If you compare, this was the right eye before the Ozurdex injection, and this is the right eye, I think in January, just a couple of weeks ago. We did the left eye Ozurdex on 10th of January, and this is his left eye OCT scan. So we'll see the live scan, how the Ozurdex behaves, and this is the scan which we took 2 weeks ago when we did Ozurdex. You could see the Ozurdex implant lying in the vitreous cavity. So we can bring his live images now.
The instrument feed, please.
So we're still waiting for his 2-week post-Ozurdex scan, which probably would be today.
Right, okay, so once again, the infrared reflectance image is highlighting a lot of changes here. So we can go on to the OCT now, Phil. And again, we can start to utilize information that we have here. So we start out with a straightforward macular-centered line scan. We track, acquire an image, and then simply where we're seeing a change. So Phil, if we look at these changes inferior to the macula, just click here. And again, we can just acquire an image there. Let's move down to this spot just here, a bit further down. So exactly wherever you're seeing the changes, you can simply drop an OCT cut through. So you don't need to be an expert in interpreting the images to see that quite clearly there are some changes here and the changes that need to be documented. Again, a vertical scan. And I'll do a macular volume as well. Okay. I'll look at the other eye then, Phil. Let's just go through this area just at about 4 o'clock, which there. And again, superiorly, this area here. That's it, perfect. And again, just a little bit higher. Okay. And macular volume scan as well. Okay, right, we'll escape there. Okay, Phil, could we just quickly look at the previous scans that we acquired, and we just had, if we just pull up the colour picture of the other eye, actually, please. Sorry, Phil. Okay. So again, this is a colour picture that we acquired just before the start of this session. Okay, and again, we can see an awful lot of important changes simply within the fundus image. Lots of highly reflective material, which is very likely to be exudate. We've got these areas here, which is all areas where we can see leakage. Okay, because this image is it's a multicolour image. It requires infrared, green, and blue light all simultaneously. We also be able to pick out the areas of leakage within a colour image. And if you think about diabetic retinopathy, all the changes in diabetic retinopathy can be very simply explained by one statement. It's caused by leaking retinal capillaries or blocked retinal capillaries. Okay? And what we're seeing here is very obviously signs of leakage. Okay? So these leaking retinal capillaries, breakdown in blood-retinal barrier. And we'll have a look at the OCT scans that we performed, Phil, very quickly because we are running out of time. And we've been reminded. Okay, and again, we're seeing evidence of intraretinal fluid, again in the nuclear layer, in the outer plexiform layer, anterior to Henle's fibre layer. And we've got a little bit of subretinal fluid here and some macular thickening. We'll have a look at the volume scan as well, Phil, quickly. Okay, just going through. And again, we see this highly reflective material within the retina likely to be exudate. Also signs of an epiretinal membrane as well as we scroll downwards. Again, probably just an incidental finding. And if we just look at the macular thickness very quickly. Okay. Now, actually, this is where the numbers actually start to become important, because in terms of treatment for diabetic maculopathy under NICE guidance, you need to have a central subfield value of 400 microns or greater to be eligible for treatment under NICE guidance. So this figure is one of the occasions where it is actually very important that we measure that. And if you're seeing a patient with diabetic macular edema in your clinic as a new referral, and you send in that information about the central subfield from the OCT, it can help an ophthalmologist immediately understand whether or not they're going to be able to offer treatment to this patient, what they're going to need to do next.
Color coding will give you an idea. If you see white here, that means it's more than 450 microns. So definitely patient needs treatment. And the advantage of OCT is help you to monitor the disease progress as well, because now we can compare this scan with the previous scan, and we can just do a serial scan every month or every 2 months and see the progress of the disease.
Okay, so unfortunately, I'm afraid to say we have actually run out of time as we come to 10:15. So thank you for your attention. I hope you have enjoyed the session. Please could we show our appreciation to our patient volunteers, please? Okay, and also our thanks to Mr. Gupta for joining us today.